It appears that in certain jurisdictions, policymakers and payers are hesitant to give primary care clinicians free reins with using PoCUS. Is this because there is general belief that primary care physicians and other clinicians do not have sufficient education and training with PoCUS? Do you have any recommendations for policymakers and payers when it comes to evaluating the role of PoCUS in primary care settings?
The reasons for policymakers and payers to be hesitant to support point-of-care ultrasound is for a number of reasons. One is that policymakers are not clear on what point-of-care ultrasound is. I think that's the main issue. Keep in mind that point-of-care ultrasound is a relatively new phenomenon whereby clinicians use portable ultrasound device at the bedside of the patient as part of their clinical assessment of the patient. So that's as opposed to an imaging specialist who is performing a complete diagnostic evaluation of a patient for a certain presenting complaint. When an imaging specialist performs an abdominal ultrasound, they look at really all the internal organs, and they have a very well prescribed sequence through which they image and interrogate all those organs. Point of care ultrasound clinicians have a much more limited approach. We answer discrete questions with yes or no answers. There's no subtlety, and we see the use of ultrasound as simply an adjunct to our physical exam or adjunct to our clinical assessment. So if somebody presents with abdominal pain, the point-of-care ultrasound practitioner asks the question, does this patient have an aneurysm of the aorta, yes or no? Because that may be one of the causes of abdominal pain. That may be the only question they look at. The imaging specialist, and so they answer yes or no, and then they add that information to the rest of their clinical information, which includes questions on appetite, vomiting, bowel movement, fever, etc., and their physical exam. So the palpation, the percussion, the auscultation of the abdomen. So they add that discrete piece of information, is there an aneurysm, yes or no, to all of the rest of their clinical assessment at the bedside of the patient, and then they decide disposition for the patient based on all of that information. The imaging specialist, on the other hand, receives the patient in the examining suite, has not asked any questions of the patient, nor examined the patient, and rather performs for them a complete ultrasound exam looking at liver, gallbladder, biliary tree, kidneys, bladder, aorta, vessels, retroperitoneal structures, spleen, on and on and on. So there are many interrogations that they make, and then from that very complete interrogation, they will give you a report on all of those organs and try and come up with why that patient has abdominal pain. So very different approach, also different in terms of time commitment. The point of care approach takes a matter of minutes. The complete ultrasound takes much longer. It is simply not practical in the office. So I think it's important that policymakers understand that that's how we're using ultrasound. They're not, when we teach point of care ultrasound, we make very clear to medical students that this information they use from the ultrasound is only a part of their clinical assessment. So always excellent history, excellent physical exam, and only then at the bedside a very focused point of care technique. So that's one reason. So that I think there's a lack of understanding of what point of care ultrasound is. There's also it's not clear how, when you talk about payers, how would you pay for point of care ultrasound, since it is a very discrete technique. So it's not clear how that would be reimbursed. And then there's a lot of, I think there's a certain degree of territorialism on the part of human beings in general. I would say that it's always the yin and the yang of human nature. So on the one hand, we are collaborative, cooperative, virtuous, and we want to help patient care. But on the other hand, we like to be recognized for our skills, and we like to be remunerated, or maybe not remunerated, but recognition is a key component of human nature. So for example, if you are a specialist who trains for 5 years on how to ultrasound the abdomen, and then you get a clinician who comes and says, "Hey, I do that too," or "I learned ultrasound too," I can imagine that can be disconcerting, and you might think, "Well, no, if it took me 5 years, I want to be recognized for that." Well, so the miscommunication there is that the point-of-care ultrasonographer is not at all trying to be an imaging specialist, at all. So there's really no overlap. They're using the ultrasound in a very different way, very time-dependent at the bedside to help in the clinical assessment. So I don't think those policymakers or imaging specialists should feel any threat or threat to their specialty at all, in terms of either recognition people get for performing ultrasound or the remuneration they perform. Because, for example, I've been using ultrasound for 10 years, and I don't bill for using ultrasound at all. So I have not been remunerated other than a very, very few times in the hospital for using ultrasound. When I use it in the office, I currently cannot bill for it, so I don't bill for it. So I'm not being a remunerator. I'm using it because I find it very useful, and I think it improves patient care. So ultimately, I think that under the guise of protecting patient safety, some organizations and some people are saying that point-of-care ultrasound, we have to be careful because it could be dangerous if people don't have adequate training. But I think it's under the guise of patient safety, but in fact, I think the real reasons have to do with misunderstandings about the real scope of point-of-care ultrasound. So when people, for example, this idea of safety, so people say this could be dangerous. Well, I don't think that's true. I think that people say that ultrasound is a user-dependent, operator-dependent technique. A couple of issues I would point out about that, and that the first is that there's a much more important clinical tool that we use every day that is also operator dependent, can cause much more damage than the ultrasound, and that clinical tool is the human brain. And the human brain is the clinical technique we use every day, and clinical judgment is something that is misused every day. So the decisions made by the human brain are much more critical to patient safety than the operator-dependent use of an ultrasound machine. So in other words, if you are a poor clinician before you use ultrasound, you're still going to be a poor clinician after. And if you're a good clinician before you use ultrasound, you're still going to be a good clinician after you add that information to your clinical assessment. So we had done some reviews at our hospital on use of point-of-care ultrasound, and we found that whenever there was an error in the use of ultrasound, it always had to do with not an actual error in the generation of an image, but an error in the use of that information, the incorporation of that information into the clinical assessment. So in other words, clinical judgment. So I don't think that there's information that bears out any concern about patient safety. In fact, in an informal discussion with American physicians who work with insurance companies, the more likely cause of lawsuits with regards to point-of-care ultrasound is not the misuse of point-of-care ultrasound, but rather the lack of use. So, for example, it is now considered standard of care to use ultrasound to guide certain procedures like the cannulation of a large vein in the neck. And so there have been cases where physicians were criticized for not using point-of-care ultrasound in that situation, and in which they caused injury to the patient when they didn't use ultrasound. So, but in informal discussions with Canadian medical insurance practitioners, most of the legal issue, the legal complaints against physicians had to do with physicians who overstepped their bounds using point-of-care ultrasound. In other words, not using point-of-care ultrasound as it should be used in a focused, discrete clinical context. And do policymakers and payers, are they clear on how point-of-care ultrasound practitioners are trained? No, they're not clear on that, and that's a very, very important issue that has to be resolved as soon as possible. For example, in Canada, a society called Canadian Point of Care Ultrasound Society is the main organization that offers evaluation of the skills of point of care ultrasound practitioners. They have a very rigorous list of criteria, the number of scans that a person needs. They have to pass a written test. They have to pass a very rigorous visual test as well. And they have to be evaluated practically by a master instructor. And only after all of that is completed are they offered what's called independent practitioner status, whereby they can use the very focused applications that this society advocates. So that society, so I think it's very important that we have well-defined credentialing techniques or methods, so that we have a very well-defined evaluation and testing system through which people can develop a credential. And I think that's important to have a uniform method like that, so that we can be assured that people have the adequate training. But once they do have the adequate training, then I think with the information available on the usefulness of point-of-care ultrasound, through discussions with these policymakers, I think the way forward is to really just educate everybody as to what it is we're doing, why we're doing it. And I think that certainly in the future, I think it will be, these policymakers will come to terms with how point-of-care ultrasound is used, and I think it will be supported in primary care settings in the near future. Well, one thing we can do other than setting up these credentialing, actually, let me just finish on that credentialing system. I'm on a committee as part of that Canadian Point of Care Ultrasound Society to devise credentials specifically for primary care. We've come up with the acronym FAMUS, FAMUS, Family Medicine Ultrasound. And the reason we did that is because most of the credentialing current credentialing has to do with emergency medicine, because they were the leaders in pioneering the use of point-of-care ultrasound. But there are many applications that are useful in the primary care setting, and so for that reason, we're setting up a credentialing system for FAMUS, or Family Medicine Ultrasound. And once that's in place, I think that you're going to see a real growth in the use of primary care ultrasound. And as part of that, we are looking into a study on the accuracy of family physicians in screening for abdominal aortic aneurysms. And I think that is one of the key applications that family physicians can learn.
Oh, fantastic. For those working on establishing a PoCUS curriculum in medical education, can you offer suggestions on the critical competencies that should be evaluated in order to ensure that PoCUS program graduates can appropriately produce and interpret PoCUS imaging?
I think you have to be realistic in undergraduate medical education. The example I would use is that when you're teaching the use of the stethoscope, you might be teaching how to listen for heart sounds or heart murmurs, but when that medical student graduates, you're not expecting them to be an expert at using the stethoscope. So when a fourth-year medical student comes to me and says there's a diastolic murmur and a split S2, I mean, am I sure that that's what they're hearing? No, not necessarily. I'm going to listen myself. So just in the same way, if somebody comes to me and says, hey, this patient has free fluid in the abdomen, I'm going to either look myself or review their images, and I mean, that's all part of medical education and supervision of skills. But as far as critical competencies, I think also the way I divide it up is with point of care ultrasound is that you need to learn about 3 levels. The first level is the ability to generate an image of a structure. The second level is to interpret that image accurately. And the third level is to integrate that information into the clinical context. And I would say in the undergraduate curriculum, we are working for the most part on levels 1 and 2, ability to generate an image of a kidney, for example, interpret what are the structures on the kidney, the image of the kidney, and then we certainly introduce why we're doing that clinically, but I'm not expecting the student to walk out completely competent in using point of care ultrasound in somebody with kidney injury. But they're taking the first steps on the way to being able to run with the device. So what are the competencies? Well, I think you have to first of all, before you start measuring competencies, you've got to make sure your curriculum is realistic and well defined. Once you've got your curriculum foundation very well defined and realistic, then you can essentially ensure that student has some core knowledge from the pre-reading, and that's easy to evaluate in terms of written tests. And then you can have the second level is to interpret images. So the first level is still to generate images. So for that, you need some practical supervision. So you need so we have an OSCE. So we ask the students to generate images, and then we evaluate their ability, both in terms of the general use of the machine, the patient positioning, the appropriate probe choice, and the generation of adequate images. So you have to define what is an adequate image. What are the structures that have to be seen in order to be deemed adequate, and then you have to evaluate that. And then you can ask the student questions on the images that they generate and to identify the structures. And then lastly, you can ask how they would use that in a different clinical scenario. But as far as core clinical competencies, that really depends on what you've decided to teach. So we chose applications that were very common and that we thought were very useful, including certain features of lung ultrasound. So all of our applications are clinically based. So in other words, the approach to the dyspneic patient using point of care ultrasound, the approach to the patient with kidney injury using point of care ultrasound, the approach to the patient with abdominal pain using point of care ultrasound, the approach to the trauma patient with using point of care ultrasound. So the student knows as they enter each modality where they're headed, that they're trying to answer a specific question. And then you just follow along the three steps. How do they generate the images technically? How do they interpret them? And then how do they integrate them? So that's the way I would do that as far as critical competencies.